What is up, beautiful people? If you know me, great. My name is Tiago and I am a nursing student. Today, we are covering the second GI video, liver, pancreas, and gallbladder. The main conditions are cirrhosis, hepatitis, variceal bleeding, hepatic encephalopathy, lactulose, pancreatitis, and cholecystitis. This is me teaching myself out loud using the same structure I use in my notes. Liver can feel overwhelming because everything connects. Albumin connects to the fluid. INR connects to the bleeding. Ammonia connects to the mental status. Portal pressure connects to the varices. And bile connects to the jaundice. This is why I'm using the Tiago 12-point clinical framework. I want each of you to know these conditions, okay? This is something that I built for me and to make sure I pass my exams, okay? And if it works for me, because it is, it might and may well work for you, and I hope it does, okay? And just a quick study note with Tiago before we start, if you want to follow along, the GI, the My Notes packets are all within the description below. You have flashcards and practice questions, and all the study tools are linked right into the description. Okay, so the point is to watch, pause, look at the visual map, and test yourself instead of just trying to hold the whole liver and pancreas in your head. All right, so let's get into it. Liver disease is not one neat system, okay? It's a chain of systems. A scarred liver cannot filter toxins well. It cannot make albumin and clotting factors well. It cannot handle blood flow well, so the patient can swell, bleed, become confused, look jaundiced, and crash from a GI bleed. If I try to memorize those separately, I get lost. If I connect them, the topic becomes a little bit more manageable. Low albumin helps explain ascites. High INR helps explain bleeding risk. High ammonia helps explain encephalopathy. Portal hypotension helps explain varices, right? Pancreatitis is similar. The pancreas is supposed to release digestive enzymes into the GI tract. In pancreatitis, those enzymes activate too early and begin damaging the pancreas itself. That explains the severe pain, inflammation, fluid shift, NPO status, IV fluids, and monitoring. The goal is to build a map that helps me answer questions and recognize the patient in front of me. Okay? And here's a beautiful view of the 12-point clinical framework that I have built for myself to really get these concepts down. Okay, so the first 8 points are the content, that layer, right? Like, what is it? What does it look like? Yeah. And the last 4 points are on most likely the exam, right? The reasoning layer. What looks similar? What is the emergency version? Yeah. Is this an assess first trap, or what is the domino chain? Yeah, that's what I built. So for like cirrhosis, that means I do not stop at scarred liver. I ask, what jobs did the liver lose, right? What complications showing up right now, right? Is this ascites or bleeding? Is it varices, encephalopathy, infection risk, or shock? What do I monitor, right? Abdominal girth, daily weight, INR, albumin, bilirubin, ammona, mental status, stool, emesis, blood pressure, right? This is why I have this, yeah? There's so many questions to ask, and once you start getting this down, then you start asking, well, what's the breakdown? Yeah, and this is why I built this, right? So let's get into it. Here's the order. So first is cirrhosis, because that is the big liver map. We are going to connect scarring to portal hypertension, ascites, varices, bleeding risk, and hepatic encephalopathy. Then we move into hepatitis A, B, and C. I want to note the transmission pattern, the vaccine pattern, the chronic risk pattern, and the teaching that keeps the patient safe. After that, we slow down for the emergency chains. Variceal bleeding and hepatic encephalopathy, these are the parts where the question can shift from what is the disease to what do you do first. Then we move into pancreas and gallbladder, pancreatitis, pancreatitis assessment, right? The priorities, the diet, right? What does it look like, and etc. The whole video is built around this idea, right? Picture it, compare it, name the trap, and trace the chain. Yeah, all right. So here we go. Cirrhosis is chronic scarring of the liver, right? Don't you love my pictures? Okay. The liver becomes hard, nodular, and less able to do its normal job. For this exam, I'm going to keep 3 liver jobs in my head. Yeah? The liver filters toxins. The liver makes proteins, including albumin and clotting factors. The liver also helps with bile, metabolism, and blood flow through the portal system. When those jobs fail, the clinical picture starts to make sense. If filtering fails, ammonia can rise and mental status can change. If albumin drops, fluid leaves the bloodstreams and collects in the abdomen as ascites. If clotting factor production drops, INR rises and bleeding risk increases. If portal blood flow backs up, varices can form and rupture. So, cirrhosis is not just bad liver. It is a patient who can swell, bleed, become confused, become jaundice, and decompensate quickly. Okay? Think of it like this. Filter, factory, clotter, filter fails, ammonia. Factory fails, albumin, clotter, fails, INR. Okay? All right. So, common causes of cirrhosis include chronic alcohol-related liver injury, chronic hepatitis B or C, and fatty liver disease. The cause matters, but the current complication usually matters more in a nursing question. So, if the question says long history of alcohol use, I use that as a clue. If it says chronic hepatitis C, I use that as a clue. But I still ask, what is happening right now? Is the patient bleeding? Is the patient confused? Is the belly swollen? Are they infected? Are they hypotensive? Are they jaundice? That is important because the backstory opens the door, but the current assessment drives the nursing priority. A stable patient with ascites is different from a patient vomiting blood. A patient with mild confusion is different from a patient who cannot protect their airway. So I do not marry the backstory, I use the backstory to find the present danger. Yeah? So cause is the history, complication is the exam question. Okay? So for cirrhosis complications, I want the cave mnemonic, okay? Cave. C. Is it coagulopathy? The liver cannot make enough clotting factors, so the patient has increased bleeding risk. A. Is it ascites? Low albumin and portal hypertension pull fluid into the belly. V. Varices. Portal hypertensive backs pressure into the fragile esophageal or gastric veins. E. Is it encephalopathy? Ammonia builds up and affects the brain. This is helpful because cirrhosis questions often walk through one of those 4 doors. If I see bleeding, I think coagulopathy or varices. If I see abdominal distension and shortness of breath, I think ascites. If I see hematemesis, I think varices until proven otherwise. If I see confusion, sleeplessness, personality change, or ascites, I think hepatic encephalopathy. Okay? Think of it like this. Cirrhosis lives in cave. Coagulopathy, ascites, varices, encephalopathy. Okay? Ascites is fluid in the peritoneal cavity. The belly becomes distended because fluid is collecting where it should not be collecting. So the 2 big mechanisms are portal hypertension and low albumin. Portal hypertension pushes fluid out. Low albumin means the bloodstream cannot hold onto fluid as well. Together, they create that swollen abdomen. What do I monitor? Daily weight, abdominal girth, right? Intake and output, right? Respiratory status, sodium, potassium, renal function, and skin integrity. Respiratory status matters because a large amount of fluid can push up the diaphragm and make breathing harder. Okay, so what does the nurse do? You teach low sodium. Okay, I'm going to say it again. Low sodium. Okay, as ordered. Give diuretics as prescribed, monitor response, and prepare for pancreatitis, right? If the ascites is severe. After paracentesis, I watch blood pressure and signs of fluid shift because removing a large amount of fluid can drop circulating volume. Think of it like this. Ascites is not just a big belly, it's a fluid problem that can become a breathing and blood pressure problem, okay? Esophageal varices are enlarged fragile veins, usually from portal hypertension. Blood has trouble moving through the scarred liver, so pressure backs up into other vessels. Those vessels were not built to handle that pressure. The danger is rupture, right? If a varix ruptures, the patient can vomit blood, pass black tarry stools, become hypotensive, become tachycardic, and go into shock. So, the clinical picture I want is simple. Cirrhosis plus hematemesis is an emergency, yeah? This is not a routine nausea complaint. This is a bleeding airway circulation problem, okay? Medications may include non-selective beta blockers like propranolol or prevention in some patients and octreotide during acute variceal bleeding to reduce portal pressure. An endoscopy and banding may be needed, right? So nursing priorities are IV access, vitals, labs, blood products as ordered, airway awareness, and preparation for urgent intervention. Okay? Think of it like this. Varices are overfilled balloons in the esophagus. If one pops, the patient can bleed fast. All right? For an active variceal bleed, I think in priorities, okay? First, recognize instability. Yeah? Vomiting blood, hypotension, tachycardia, dizziness, altered mental status, or signs of shock means this is urgent. The nurse should not treat it like a normal GI upset. Yeah? Second, support circulation and prepare for intervention. Expect large bore IV access, right? Fluid or blood product support as ordered. Labs, type and screen, continuous monitoring, and urgent provider or rapid response involvement, depending on the situation. Yeah. Third, anticipate treatments. Okay. Octreotide may be used to reduce portal blood flow and pressure. Antibiotics may be ordered because the infection risk rises in cirrhosis and with GI bleeding. Endoscopy can diagnose and treat the bleeding source, often with like a band or ligation. Yeah. The test strap, yeah, is picking a calm teaching answer when the patient is actively bleeding. Teaching comes later, right? During the bleed, the priority is circulation, airway awareness, yeah, and stopping the bleeding. Okay? So think of it like this. Bleeding varices are not a teaching moment, okay? They are stabilize and stop the bleed, okay? Boom. Ugh, I love my pictures. I really do. I honestly, I really, this is why I do this. Like, who else is going to remember this? I mean, you're going to remember this because I would. Anyway, hepatic encephalopathy is brain dysfunction caused by liver failure, right? Commonly connected to ammonia buildup. Normally, the liver helps process ammonia, right? So when the liver cannot clear it well, ammonia can rise and affect the brain. The patient may become forgetful, sleepy, confused, irritable, or disoriented. right? They may have Ascites, right, which is the flapping hand tremor, right? So severe cases can progress to decreased level of consciousness and coma. The key nursing assessment is mental status. I want baseline and trend. Is the patient more confused than earlier? Are they harder to wake? Are they at risk for falls? Can they protect their airway? Are they taking lactulose? How many stools are they having? All right, this is where the framework helps. Yeah, so what it does, what does it look like, right? What do I do? What do I monitor? What do I do? And what's the emergency version, right? So confusion in cirrhosis is not just they are tired. It can be a liver complication. All right, so think of ammonia fogs the brain. Lactulose helps move that fog out through stool. I'm going to say that again. Ammonia fogs the brain. Lactulose helps move that fog out through the stool. Okay? All right. Lactulose is used in hepatic encephalopathy because it helps lower ammonia. It traps ammonia in the gut and promotes excretion through the stool. Yeah? The teaching point is the stool goal, right? The goal is usually 2 to 3 soft stools per day, depending on the plan. If if they're not having any stools, ammonia may not be clearing well. If there is too much diarrhea, the patient can become dehydrated and lose electrolytes. So, I monitor mental status, stool frequency, hydration, potassium, and other electrolytes, right? Abdominal cramping, and whether the patient is actually taking the medication. Patients may dislike lactulose because it causes gas and cramping and diarrhea. So the why matters. This is not just a laxative, this is a treatment for ammonia-related confusion. The evaluation question is the patient more alert, more orientated, and stooling at the ordered goal without dehydration. So think of lactulose has a purpose, right? Poop out the ammonia, but do not dehydrate the patient. Okay? Okay. So Cirrhosis labs makes more sense if I tie it to a job, yeah? So albumin is about fluid holding, yeah? If albumin is low, fluid can leave the vascular space and contribute to edema and ascites. INR and PT are about clotting. If INR is high, the patient has increased bleeding risk because the liver is not making clotting factors well. Ammonia connects to mental status. If ammonia arises, right, I watch for confusion, sleeplessness, right, asterixis, and worsening encephalopathy. Bilirubin connects to the bile and handling jaundice, right? If bilirubin rises, the patients may look yellow, have dark urine, pale stools, or itching, right? So platelets can be low in chronic liver disease, especially with portal hypertension and splenic involvement, which adds to the bleeding risk, right? So sodium and kidney function matter because cirrhosis can affect fluid balance and renal perfusion. So the point is not to memorize a lab list. The point is to ask what the lab warns me about. So think of it like this. Albumin is fluid, INR is bleeding, ammonia is brain, bilirubin is bile. Okay? So, using my 12-point Tiago clinical framework, let's lock this in. All right? So, what does cirrhosis look like, right? What is it? Chronic scarred liver. What does it look like? Right? It's jaundice, it's ascites, edema, bruising, bleeding, fatigue, confusion, and sometimes GI bleed. What goes wrong? Portal hypertension, varices, ascites, hepatic encephalopathy, infection risk, renal problems, and shock if bleeding is severe. What do I do? Right? You gotta daily weight, abdominal girth, INO, mental status, stool, anamnesis for blood pressure, heart rate, INR, albumin, bilirubin, ammonia, platelets, sodium, potassium, and renal function, right? What does the nurse do? Bleeding precautions, right? Fall precautions, medication administration, right? Lactulose monitoring, ascites management, infection awareness, and rapid recognition of emergencies. What do I teach, right? You teach avoid alcohol, take medications as prescribed, follow sodium guidance, report black stools or vomiting blood, right? Report worsening confusion, and verify all the medications and supplements because the liver is vulnerable. So, the emergency versions, yeah, are variceal bleed, severe encephalopathy, infection with decompensation, and shock. The chain is scarred liver to portal pressure to varices or ascites, and failed detox to ammonia to brain changes. So, here's your memory hook, right? Cirrhosis is the whole liver map. Scar, pressure, fluid, bleeding, brain. Okay? Hepatitis means inflammation of the liver. For nursing exams, I want to separate A, B, and C by transmission and chronic risk. So, hepatitis A is usually fecal, oral, right? Think contaminated food, water, or close contact. Yeah. It is usually acute and there is a vaccine, right? Teaching focuses on hand hygiene, food, and water safety and preventing spreads. Okay. Like, oh my God, I don't even want to go too far into this, but yeah, wash your hands, right? Right? Wash your hands first. Don't do anything else. All right. So, hepatitis B spreads through the blood and body fluids, right? That includes sexual contact, needle exposure, peritoneal transmission. There is a vaccine, and chronic infection can happen. Hepatitis C is mainly blood exposure and as a higher chronic risk pattern, right? Modern treatment can cure many patients, but the key for the exam is chronic liver disease risk and screening in the right context. Yeah. So for all hepatitis, I connect it back to the liver, right? So fatigue, jaundice, dark urine, right upper quadrant, discomfort, nausea, elevated liver enzymes, and teaching to avoid alcohol and protective liver. Now here's your hook. Yeah. A is what you ate. B is body fluids and vaccine. C is chronic blood risk thinking. Okay. Hepatitis teaching is about preventing spread and protecting the liver. So, for hepatitis A, focus on hand hygiene, yeah? Safe food and water, and staying home or following guidance during the contagious spread, right? Or the period. Household contacts may need evaluation, maybe depending on the situation. For hepatitis B, focus on vaccination, safer sex, not sharing razors or toothbrushes, not sharing needles. We don't do that, right? And blood exposure, right? Precautions, okay? So the patient should understand that the household casual contact is not the same as blood and body fluid exposure, okay? So hepatitis C, focus on the blood exposure, right? Precautions, not sharing needles, for God's sakes. I don't know why we sharing needles, right? Or personal items that may have blood, right? Screening, follow up, and treatment adherence is prescribed, yeah? For liver protection in general, avoid alcohol, right? We should always avoid alcohol, but check before using acetaminophen or supplements, right? Take medications only as directed and report worsening jaundice, right? Confusion, bleeding, severe abdominal pain, or vomiting blood, okay? Here's your memory hook, yeah? Hepatitis teaching has two lanes. Protect other people from exposure and protect the liver from more injury. All right. Now, I want the variceal bleed chain out loud, right? So let's do it together. Cirrhosis scars the liver, right? Scar tissue increases resistance to the portal blood flow. Portal pressure rises. Blood backs into the fragile veins in the esophagus or the stomach. Those veins enlarge into varices. If a varices rupture, the patient can vomit blood and lose circulating volume quickly. That can lead to hypotension, tachycardia, right? Shock, and death if not treated. The nursing response follows the chain. If the danger is bleeding and shock, I monitor the airway and breathing circulation. What is that called? C. I'm going to say this again. The nursing response follows the chain. Yeah. If the danger is bleeding and shock, I monitor airway and breathing and circulation, right? Vital signs, mental status, and blood loss. I prepare for IV access, okay? Labs, blood products, and medications, and endoscopy as ordered, yeah? So the assess first trap depends on the stability. If the patient is stable and reports mild symptoms, assessment can come first. If the patient is actively vomiting blood and hypotensive, this is not a slow assessment. Okay, this is an urgent escalation and stabilization. All right, so scar to pressure, pressure to varices, varices to rupture, and rupture to shock. Okay, now encephalopathy chain. The liver normally helps process toxins like ammonia. In severe liver dysfunction, ammonia can build up. Yeah, the brain becomes affected. The patient may show sleep changes, irritability, confusion, poor concentration, ascites, however you say it, decreased level of consciousness, or coma. Yeah, the nursing response is the trend mental status. Reduce fall risk, monitor airway, risk if conscious drops, yeah, give lactulose as ordered, monitor stool goal, yeah, monitor hydration and electrolytes, and evaluate whether mental status improves. The question trap is treating confusion like it is only dementia, aging, or anxiety. In a patient with cirrhosis, new confusion is a clinical warning. I need to connect the symptom to the liver and ask the next safe nursing action. Okay? So remember this, liver cannot clear, ammonia climbs. Brain fogs, lactulose clears. All right? Okay, here is your priority thinking. Okay? Stable patient usually means assess first. If a patient with cirrhosis says their abdomen feels more full, I assess abdominal girth, weight, respiratory status, right? Pain, and related findings. If a patient is mildly confused but breathing and perfusing, I assess mental status and safety and medication adherence and labs. Unstable patient means act first. Vomiting bright red blood, low blood pressure, tachycardia, severe altered mental status, respiratory distress, or signs of shock. Changes the priority, okay? Then I think airway, breathing and circulation, urgent escalation, right? IV access and monitoring and labs and treatment preparation, okay? This is why I do not memorize one universal answer because there isn't. The patient stability decides whether I slow down the assess or move into the emergency actions, okay? So you stable lets me investigate, okay? Stable lets me investigate. Unstable makes me intervene. All right? So the old teaching trap is using extreme forever rules without context. Okay? So, like, nutrition matters in liver disease, but the exact plan depends on the patient. Current labs, provider plan, and course guidance. Yeah? So I should avoid turning one fact into a blanket rule. For an example, protein teaching in hepatic encephalopathy can be nuance. The goal is not to casually tell every liver patient to avoid protein forever. The goal is to follow the current plan, protect nutrition, and monitor mental status and ammonia-related symptoms. The same idea applies to sodium, right? Fluids, medications, alcohol, and supplements. Low sodium may matter for ascites. Alcohol avoidance matters for liver protection, right? So the medication safety matters because impaired liver function changes risk. But I still verify the plan instead of the inventing rigid advice. Okay, so let's say for an exams, the safest answer usually respects the complication in front of me and avoids extreme wording unless the situation clearly calls for it. Okay? Okay. Let's recap the liver before moving into the pancreas, okay? So cirrhosis is scarred liver, right? The big complications are coagulopathy, ascites, varices, and encephalopathy. Ascites is the belly fluid, right? I monitor daily weight, abdominal girth, INO, electrolytes, renal function, and respiratory status, yeah? Varices are fragile veins under the high portal pressure, right? Hematemesis in cirrhosis is an emergency until proven otherwise. Hepatic encephalopathy is an ammonia affecting the brain. Ammonia affecting the brain. Ammonia affecting the brain. I monitor mental status, safety, lactulose response, right? The stool gold, the hydration, the electrolytes. Hepatitis is liver inflammation. A is fecal oral, right? B is blood and body fluids with vaccine protection. And C is blood exposure with chronic liver risk and modern treatment options. Okay, so the liver map is bleeding, belly, brain, and bile. Okay, if I can say bleeding, belly, brain, and bile, I can rebuild most of the liver sections. Okay. Ooh, pancreatitis, inflammation of the pancreas, okay? The simple picture is that digestive enzymes activate too early and start injuring the pancreas itself. That explains why pancreatitis can be so painful. The classic pain is severe epigastric pain that may radiate to the back. The patient may have nausea, vomiting, fever, tachycardia, abdominal tenderness, and may look very uncomfortable. Yeah? Common causes include gallstones and alcohol related injury. But again, I ask what is happening right now? Is the patient hypovolemic? Are they severe pain? Are they vomiting? Is their glucose abnormal, right? Are they developing respiratory issues or complications, right? Lipus is a key lab because it's more pancreas specific than amylase. I also watch for glucose because the pancreas affects insulin, calcium because it can drop in a severe pancreatitis, and renal function and urine output because fluid shifts can threaten perfusion. So, pancreatitis is the pancreas getting burned by its own digestive stools. Okay, that's your memory. Okay, I'm going to say it again. Pancreatitis is the pancreas getting burned by its own digestive tools. I said stools or tools? Tools. Okay. Assessment for pancreatitis starts with the pain pattern and the systemic picture. The pain is usually upper abdominal or epigastric and may radiate to the back. Okay, it may worsen after eating. The patient may lean forward or curl up because they are trying to reduce the pain. Nausea and vomiting are common, right? Then I check the complication signs. Fever, tachycardia can show inflammation or infection concern. Hypotension, poor urine output, dry mucosa membranes, right? The rising BUN and can suggest dehydration or third spacing. Respiratory changes matter because severe pancreatitis can affect the lungs. Gray Turner signs or Collins signs can suggest bleeding in severe cases. Through those are not always present, okay? My nursing brain should not stop at lipus is high. Okay, I want the whole patient, right? The pain, fluids, oxygenation, the glucose, the calcium, the urine output, and the signs of deterioration. So, pain to the back, is that a clue? Fluids and breathing tell me how sick the patient is, okay? Pancreatitis. The priorities are about resting the pancreas. Right? Supporting circulation, controlling pain, and watching for complications. NPO may be ordered early to rest the pancreas, depending on the plan, right? So IV fluids are important because inflammation can cause major fluid shifts into the tissues. Pain control matters because this can be severe pain, not mild stomach upset. Antiemetics may be used for nausea and vomiting. I monitor vital signs and pain, lung sounds, oxygen saturation, urine output, electrolytes, glucose, calcium, and labs if the patient is getting worse. I look for shock, respiratory distress, infection, bleeding, or organ dysfunction. The priority trap is picking diet teaching while the patient is acute and unstable. Maybe I came across that mistake myself. Okay. So diet teaching matters, but in an acute pancreatitis, the immediate focus is fluids, pain, NPO as ordered, and monitoring. Okay. So think of acute pancreatitis as rest, fluids, pain control, and watch the crash signs. Diet teaching depends on the phase of the pancreatitis. During the acute phase, the patient may be NPO or have limited intake as ordered, right? The idea is to reduce pancreatic stimulation while inflammation is active. When the diet is restarted, teaching often includes small, frequent meals, low fat choices, avoid alcohol, and following the prescribed plan. If the chronic pancreatitis is involved, pancreatic enzymes replacement may be prescribed with meals and snacks to help digestion. Alcohol avoidance is major safety point, okay? Especially when alcohol contribute to the pancreatitis. Fatty meals can trigger symptoms because fat digestion stimulates pancreatic and biliary activity. So the teaching line is not never eat normally again. The teaching line is follow the staged plan. Avoid alcohol. Avoid it. Sorry. Reduce fat as directed. Take enzymes if prescribed and report worsening pain, fever, vomiting, jaundice, or signs of dehydration. So, what am I going to remember? Acute phase, rest the pancreas, recover, okay? The recovery phase, low fat, no alcohol, follow the plan. All right? Pancreatitis can look like other abdominal or chest problems, right? So I want the comparison layer. So peptic ulcer disease can cause epigastric pain too, but it's more connected to mucosal injury, right? The meal timing, the bleeding, and the perforation risk, right? Remember my other video? Go check it out. So gallbladder disease often causes right upper quadrant pain after a fatty meal, right? And may radiate to the right shoulder. MI can cause epigastric discomfort, nausea, and sweating, especially in atypical presentations. So, cardiac red flags matter. Appendicitis usually starts around the umbilicus and moves to the right lower quadrant. So, pancreatitis points me towards severe epigastric pain radiating to the back. Nausea and vomiting, elevated lipus, and systemic inflammation. If the question gives alcohol use or gallstones plus pain to the back, pancreatitis moves higher on the list. The exam goal is not to diagnose like a provider. The nursing goal is to recognize the pattern, know the monitoring, and avoid the missing emergencies. Yeah? All right? Because that's the basics of these questions that I keep coming across. And that's how I was able to analyze and break all these things down. Okay? So, back radiating epigastric pain with high lipus belongs in the pancreas bucket. All right? So, cholecystitis is inflammation of the gallbladder often from gallstones, right? Blocking bile flow. The classic picture is right upper quadrant pain, especially after fatty meal. Pain may radiate to the right shoulder or the scapula. The patient may have nausea, vomiting, fever, and tenderness. Murphy signs is pain or inspiratory pause when the provider palpates the right upper quadrant during inspiration. If bile flow is blocked, jaundice, dark urine, pale stools, right, or elevated bilirubin may show up. That helps connect gallbladder disease back to bile. The nursing care includes pain and nausea management as ordered, NPO if ordered, IV fluids as needed, monitoring temperature and labs, and preparing for imaging or surgery if indicated, right? So, think gallbladder pain is the fatty meal, right? Right upper quadrant and right shoulder story, okay? So, after cholecystectomy, right? Teaching depends on whether it was laparoscopic or open and what that care plan means. And open means, laparoscopic is the tools that they go into your stomach and then they inflate the stomach and then, it's very it's a minimal procedure, right? But open means depending where, right, or how they want to enter, it's going to be towards the lower abdomen and they might make a bigger incision. So that's, different complications. So the common teaching includes early ambulation, splinting with coughing or movement, incision care, right, pain control as prescribed, and watching for infection signs such as fever, increasing redness, drainage, or worsening pain. Diet teaching often includes starting with like lower fat foods and gradually advancing as tolerated. But because bile flow changes after gallbladder removal, some patients have temporary loose stools or difficulty with fatty foods. So the red flags I want to teach are fever, jaundice, abdominal pain, right? Persistent vomiting, dark urine, pale stools, or signs of infection. Those can signal bile duct issues. The infection or another complication. Okay, so post-op coli, right? The teaching is walk, right? Wounds, low fat at first, and report fever or jaundice. Okay. All right. Let's lock this in. Okay, using my Tiago framework. Okay, so pancreas and gallbladder. Pancreas, what is it? Inflamed pancreas from early enzyme activation, right? What does it look like? Severe epigastric pain radiating to the back, right? Nausea, vomiting, and elevated lipus, right? What goes wrong? Fluid shift, shock, hypocalcemia, glucose problems, respiratory issues, infection, and organ dysfunction. What do I monitor? Pain, vitals, oxygen, urine output, right? The glucose, calcium, and lipase and renal function, and hydration. What does the nurse do? Rest the pancreas as ordered. Give IV fluids, manage the pain and the nausea, monitor closely, and report deterioration. Cholecystitis. What is it? Inflamed gallbladder, often from stones. What does it look like? Right upper quadrant pain after a fatty meal, nausea, vomiting, fever, and Murphy signs. What goes wrong? Infection, obstruction, jaundice, or bile duct complications, yeah? What do I teach? Low fat choices at first after surgery, ambulation, incision care, and red flag reporting. Okay, so here's your hook. Pancreas is back pain and enzymes. Gallbladder is right upper quadrant pain and bile. Okay, so the comparison table is where I want to pause and sort the topics, right? So cirrhosis is chronic scarring. Its danger pattern is fluid, bleeding, brain changes, portal pressure, and liver failure signs. Hepatitis is inflammation. Its danger pattern is transmission, it's liver injury, it's jaundice, fatigue, and chronic risk teaching, depending on A, B, or C, right? Pancreatitis is enzyme injury. Its danger pattern, it's severe epigastric pain radiating to the back, vomiting, fluid shifts, glucose and calcium problems, and possible respiratory or shock complications. Cholecystitis is a gallbladder inflammation, right? Often from stones. It's a danger pattern. It's a right upper quadrant pain after fatty meals, or fever, or Murphy signs, right? Or jaundice if the bile is blocked, right? And post-op teaching after cholecystectomy. The table is not here for decoration, okay? It is here so I can ask, where is the pain? What's the body system failing? What lab matters? And what is the emergency? And what action fits the condition? Okay, so quick one. Cirrhosis scars, hepatitis inflames, pancreatitis digests itself, and cholecystitis blocks bile. Now, the final domino map, okay? Cirrhosis can go scarred liver to portal hypertension, to varices, to bleeding shock, right? The chain tells me to monitor bleeding, blood pressure, heart rate, mental status, and prepare for urgent treatment. Cirrhosis can also go scarred liver to poor ammonia clearance, to confusion, to falls, aspiration risk, or coma. The chain tells me to monitor mental status, safety, lactulose response, stools, hydration, and electrolytes. Ascites can go low albumin and portal pressure to abdominal fluid, to shortness of breath or infection risk, right? The chain tells me to monitor weight, girth, respiratory status, pain, fever, and blood pressure after fluids removal. The pancreatitis can go early enzymes activation to inflammation to the third spacing to hypovolemia, respiratory issues, and organ dysfunction. That chain tells me fluids, urine output oxygenation, and glucose, calcium, and pain control matter. Okay, this is the whole reason for the chain language. The chain tells me what to watch next. Okay. Final framework check. Okay, let's just do it together. If I say cirrhosis, I should be able to answer what jobs did the liver lose, right? What's the complication that's showing up? What do I monitor? And what the emergency could happen. If I say hepatitis, I should be able to answer, how does this one spread? Is there a vaccine? What chronic risk matters? And what liver protection teaching is needed? If I say pancreatitis, I should be able to answer, what does the pain look like? What lab points to the pancreas? Why fluid matters? And what complications I'm watching for? If I say cholecystitis, I should be able to answer, where is the pain? What meal pattern triggers it? What Murphy sign is and means and what post-op teaching keeps the patient safe. That is enough to make the content usable, right? So not perfect, not usable. The goal is to walk into the questions and to know and to know what you're looking into and answer it, right? This is why I built this, okay? That is the liver and pancreas for adult health and med surg, okay? If you are using this to study with me, pull up the GI in my note packet with the video. The packet is built to match this kind of flow, right? The conditions, the pictures, the nursing priorities, comparison points, and red flags. The memory cues, all of it, okay? All of it is there. And again, this study is to support from a nursing student, okay? I am a nursing student, okay? Verify everything against your own current course, materials, instructor guidance, and facility policy and clinical standards, of course, okay? If this helped you, leave a like and a comment what topic you want me to do next, and subscribe, please. You can study with me, and I am building this for myself. And if it helps you too, I am genuinely glad for you, okay? And I am grateful for you being here and watching with me, okay? So I will see you on the next one. You got this. I got this. We got this. Tiago out.